Hi friends, so today we will learn iron deficiency anemia. This is a very important topic for your theory exam, practical exams as well as clinical practice. Why? Because this iron deficiency anemia accounts for about 50% of the cases of anemia worldwide, and it accounts for about 1 million deaths annually all over the globe. Okay, so you might be wondering why I have kept a picture of a nail in the opening slide. If you carefully look at that nail, it is deformed. It is deformed to such an extent that it looks like a spoon actually. So it can carry a drop of water inside this. So this is a hallmark or classical finding you may get in iron deficiency anemia. This is otherwise called as koilonychia. It comes from a Greek word. Koilos means hollow and onik means nail. So with this classical sign in mind, we will start the topic. So we'll start with a case scenario. A 50-year-old male presents to OPD with excessive tiredness and breathlessness. He also gives history of passing sticky, tarry stools for the last few weeks. On examination, he is pale, his nails are flat, and there is a short systolic murmur in the pulmonary area. So what is your diagnosis? What is the most probable etiology, and how will you proceed further? At the end of this session, we will be able to answer this case scenario. Okay, we will see the keywords. These are actually different subheadings: stages of iron deficiency, iron indices in iron deficiency anemia, differential diagnosis in microcytic hypochromic anemia, and treatment of iron deficiency anemia. I have kept these words because any of these can be asked as a short note in your university theory exam. Okay, so we will start with the pathogenesis of iron deficiency anemia. I have divided the pathogenesis into 3 stages, but you should be familiar with these words like ferritin. What is ferritin? Ferritin is actually a storage form of iron. Whenever there is an excess iron, this will be stored as ferritin, just like a bank deposit. So whenever there is excess ferritin, this can be complexed with proteins and this will be stored as hemosiderin. The basic difference between these two is that ferritin is freely available for different activities, but hemosiderin is not that freely available. So the first stage of pathogenesis is stage of negative iron balance, in which your ferritin only is affected. Your ferritin decreases as well as your stainable iron in bone marrow decreases. All other parameters like serum iron, total iron binding capacity, and the RBC morphology, everything remains normal. In second stage, the second stage is always called as iron deficient erythropoiesis. As the name suggests, your serum iron is low. Whenever serum iron is low, your total iron binding capacity will go up. And the ferritin, it is already low. Suppose your ferritin is less than 15, it means that your bone marrow iron store is depleted, totally depleted. Okay, so what happens to cells in peripheral smear? You will be seeing microcytosis as well as hypochromia. The third one is the classical iron deficiency anemia, where you will be getting microcytic hypochromic anemia. Your hemoglobin level falls, your total iron binding capacity increases, transferrin saturation comes down, and your ferritin is almost a single digit. Okay, so what are the causes or etiology of iron deficiency anemia? You can take it as decreased, 2 decreased and 2 increased. Whenever there is a decreased intake due to an inadequate diet in extremes of age, or whenever there is a decreased absorption due to illnesses like malabsorption, a surgery of stomach or upper intestine. These are the areas where which is concerned with iron absorption. Or whenever there is an acute or chronic inflammation of your gut, or whenever there is a chronic proton pump inhibitor use, just like your pantoprazole or ramiprazole, this can produce an alkaline medium. Acidic medium is required for iron absorption. Okay, either decreased intake or decreased absorption. The next set is actually increased demand or increased loss. Whenever there is conditions like puberty, infancy, pregnancy, these are the conditions where the iron demand is increased. For people on erythropoietin therapy, they need excess iron, just like patients on CKD patients. Okay, and increased loss, basically there are 2 types. One is a menstrual loss, other one is a gastrointestinal loss. So women of childbearing age always think about a menstrual loss, and any other males or postmenopausal women always think about a gastrointestinal loss. And there are some rare conditions like people who give blood frequently, or patients like polycythemia rubra or other conditions where phlebotomy is used as a treatment. In those conditions also you may get iron deficiency anemia. So for your clinical practice, always keep in mind these 3 points. In children and adolescents, a parasitic infestation of your gut, like hookworm infestation, is the most common cause of iron deficiency anemia. And women of childbearing age, always think about a menstrual bleed, like condition producing menorrhagia. And in all others, like men of any age and postmenopausal women, always think about gastrointestinal loss. Otherwise, you may miss a gastrointestinal malignancy. Okay. So, what are the clinical features you will get in iron deficiency anemia? Just like any other anemia, the early symptoms are same. The patient will have AC fatigue. They will develop shortness of breath. They will have poor effort tolerance, and they can have pre-syncope or syncopal symptoms, and they can have pica. Pica is actually craving for substances of no nutritional value, something like clay or soil. And at times you may get history of melena when your cause of iron deficiency anemia is a gastrointestinal loss. To be exact, upper gastrointestinal loss. Okay. On clinical examination, you will get a pale conjunctiva, that is pallor. You can get a angular chelosis, which is shown in this picture, or you can get a spoon-shaped nail, which I told earlier, which has got a hollow area. Or in pulmonary area, you can get a flow murmur, which is otherwise called as an innocent murmur. Now, how will you investigate iron deficiency anemia? The best screening test for iron deficiency anemia is serum ferritin. No doubt about that. But for your exam purpose, always start with complete blood count. If you do a complete blood count, your hemoglobin will be decreased. What happens to your mean corpuscular volume? It is microcytic hypochromic anemia, so MCV will be decreased. The only thing that is increased will be red cell distribution width. Okay, RDW will be increased. If you do a peripheral smear, you will get microcytic hypochromic anemia. That is the classical thing. And you can proceed with iron studies. In iron studies, everything will be decreased. Like ferritin will be decreased, iron will be decreased, transferrin saturation will be decreased, but only thing that is increasing is total iron binding capacity. Only TIBC will be increased in iron studies. Okay, so considering the DDs of microcytic anemia, it is very simple. Just remember these 4: iron deficiency anemia, anemia of chronic disease, thalassemia, and congenital sideroblastic anemia. This will be dealt separately later. And if you consider the iron indices in iron deficiency anemia, this itself can be asked as a short note. First, you should know the normal iron values. The serum iron normal value will be 50 to 150 microgram per deciliter, and the ferritin value will be between 50 to 200 microgram per liter. Just remember these units. So it is almost similar, 50 to 150 and 50 to 200. And your total iron binding capacity is usually between 300 to 360, and transferrin saturation is between 30 to 50%. In iron deficiency anemia, your serum iron will be usually less than 30, ferritin will be less than 15, total iron binding capacity, as I already told, it will be increased, it will be more than 400, and transferrin saturation comes down. At the late stages, it will be less than 10%. Okay. Now, the second set of investigations will be to find out the etiology of iron deficiency anemia. So, if you are suspecting a parasitic infection, like in children or adolescents, you can do a stool local blood as well as stool parasites for hookworm, ova, all those things. If you are suspecting gastrointestinal malignancy, go for an endoscopy, both upper and lower GI endoscopy, to look for a pathology, something like a malignancy. And if you are suspecting menorrhagia, do a USG pelvis. If you are suspecting a GI malignancy, do a USG abdomen. If you are still in doubt, you proceed with CT scan of abdomen. And CEA, what is CEA? CEA is otherwise called as carcinoembryogenic antigen, which is a tumor marker for GI malignancy. And tissue transglutaminase, that is for completion sake only. This can be a clue for underlying celiac disease. Okay. Now, the management of iron deficiency anemia, this is a short note actually. There you have got 3 options. First is oral iron therapy, which is the most preferred method. Parenteral iron therapy or IV iron, which has got certain indications. And the last one, during emergency phase, you can go for a red cell transfusion. So, more about oral iron therapy, you have got multiple number of preparations. You have got ferrous sulfate, ferrous fumarate, ferrous gluconate, and as well as these are recent ones, polysaccharide iron. So you will be giving 200 milligram of elemental iron. It will be given as 3 to 4 divided doses. If you are given conventional agents like ferrous sulfate or ferrous fumarate, there will be at least 50 milligram absorption per day. So this is usually continued for at least 6 months after anemia correction. 6 months after anemia correction to replenish the stores. And what will be the first response? The first response will be reticulocytosis, which was once asked as an MCQ during entrance exams. The first response happens in 4 to 7 days, and usually your hemoglobin increases by 1 gram in 10 days. And later the response comes down. Okay. What is the problem with oral iron preparation? The most prominent adverse effect is gastrointestinal intolerance. People will develop bloating sensation, they will develop nausea, vomiting, constipation, dark colored stools. So that is the main problem with oral iron therapy. The second option is parenteral iron therapy. So what are the indications for giving parenteral iron therapy? So remember these three. When your patient is intolerant to oral iron, they are developing GI upset, constipation, not willing to take oral iron. That is one indication. The second one is chronic gut disease. Somebody having a stomach or upper intestinal pathology where your iron absorption is very poor, you can go for parenteral iron therapy. The third one is you need an iron therapy on an ongoing basis. Just like your dialysis patient, you require more amount of iron, or they are on erythropoietin therapy, they want excess iron. In that condition also you can go for parenteral iron therapy. So these are the preparations. These are the older preparations actually. Iron dextran and iron sucrose. They have got allergic reactions. So these are recent preparations like ferric carboxymaltose, which carries less risk of allergy. And you should learn this equation by heart. The dose of parenteral iron therapy is body weight into 2.3 multiplied by hemoglobin deficit. If 15 is taken as normal and observed value is 10, the deficit will be around 5. Plus, you will be given extra 500 milligram to replenish the stores. So this is the calculation for parenteral iron therapy. So what are the adverse effects? Just like any infusion, they can have allergic reactions, they can have fever, rash, joint pains, and the most dreaded one is anaphylaxis. So when your patient develops chest pain, wheeze or hypotension during infusion, suspect anaphylaxis and stop the infusion immediately, treat anaphylaxis. Okay. So the third option is red cell transfusion or blood transfusion. The indication is when your patient is symptomatic anemia in elderly, or your patient is having cardiovascular instability. It will be either in the form of angina, or your patient will be having congestive cardiac failure, or when your patient is having continued and excessive blood loss where parenteral iron therapy is not sufficient. These are the three indications for giving the RBC transfusion or blood transfusion. Adverse reactions, just like any transfusion, remember transfusion reactions, which will be taught later. And remember these two terms, TRALI. TRALI means transfusion related acute lung injury, and anaphylaxis, of course, anaphylaxis. Okay. Now we will see some questions. MCQ 1. We have got a young female presented with iron deficiency anemia. False is a decreased serum ferritin. Of course, your serum ferritin will be decreased. That is true. Decreased total iron binding capacity. Whenever there is iron deficiency anemia, total iron binding capacity increases. The next one is microcytic hypochemic anemia, that is classical of iron deficiency anemia, that is true. And the fourth one is pica. Pica is actually craving for substances of no nutritional value, that is also true for iron deficiency anemia. MCQ 2, the earliest sign of iron deficiency anemia is increase in total iron binding capacity is true, but the earliest sign of iron deficiency anemia is a decrease in serum ferritin. So that is why it is usually done as a screening test for iron deficiency anemia. Okay, I will go to question number 3. Which of the following is true regarding iron replacement therapy in iron deficiency anemia? What is true? Parenteral iron to be given till the hematocrit normalizes? No. The preferred one is oral therapy. Parenteral has got its own indications, but it has no point like this. Okay. The second one, before giving parenteral iron, dilute the dose and watch for anaphylaxis. That is absolutely true. You should give a diluted form of parenteral iron and you should watch for development of anaphylaxis. The third point, 50% iron given absorbed in 325 milligram for a sulfate tablet. Now, if you are giving 200 milligram of elemental iron, around 50 milligram will be absorbed. Okay. Because of the side effects of oral iron, always give parental iron for treatment. Definitely not. We are afraid of anaphylaxis. Always try to give oral iron therapy if possible. Okay. Now these are my references: Davidson's Principles and Practice of Medicine and Harrison's
Docemy.